Thank you for watching this webinar. What we're going to do is, as part of the BSAVX Student Focus 2021, we're going to try and cover identification and treatment of heart failure in the emergency patient. Now, my name is Kieran Borgia, I'm a cardiologist. My approach may be slightly difficult, maybe it is, different to some critical care specialists out there. But I think broadly speaking, it's a rational thing to do and is based in theory and experience of doing this myself. I am currently clinical lead at Langford Vet at the University of Bristol in cardiology, and I don't have any conflict of interest to declare. Thinking about emergency heart failure, what we're going to do today is we're going to try and focus on dogs, just because they are much more commonly going to come in with these emergent signs of heart failure. However, cats are quite particular, and to cover cats in the same lecture I think would be too challenging. That's a very different subject. My advice with cats is generally go slow, take your time, less is more. So the aims are primarily discuss pathophysiology of acute presentations, why do patients present with acute heart failure in the first place. We're going to talk about options for treatment beyond the intravenous furosemide, and we're going to consider different endpoints and when to think about euthanasia for these patients. The answer, of course, is if you are having trouble with an owner with finances or a patient who's very refractory to treatment. Of course, euthanasia is never the wrong thing to do, but what I'm going to try and do is give you a bit more in your toolkit that you can use to try and get these patients through that, because actually survival time can be good beyond this acute episode. So just because they've got heart failure where you give them a dose of IV furosemide and they don't get better immediately, that doesn't mean it's the end of the road. There's much more you can do in primary care practice. So just to clarify the definition of heart failure I'm going to be using, it's a clinical syndrome caused by fluid accumulation. So we're talking about here pulmonary edema, pleural effusion in cats, and ascites. Now, pulmonary edema and pleural effusion in cats are both signs of left-sided heart failure. In dogs, pulmonary edema is a sign of left-sided heart failure, but pleural effusion and ascites are really the preserve of right-sided heart failure in canine patients. The reason for that is probably differences in anatomy and also differences in how tolerant cats are to increased pressure within the pulmonary vasculature versus dogs. Probably cats are less tolerant, and therefore when the left heart fails, the right heart fails too. They also do have slightly different venous drainage anatomy of the pleural space versus dogs, and therefore that could contribute to the problem as well. So we're focusing on dogs, we're focusing on pulmonary edema, and you can see in this radiograph here that we've got on the left here, we've got cardiomegaly, we've got sort of increased greyness to the lungs, that's an alveolar pattern, and we also have vascular distension, and we can see that. We'll look at a few more of these examples, but I'll just highlight using the laser pointer. We've got blood vessels here, we've got the artery, grey gap in the middle, that's the bronchus, and then we've got the vein. The vein is wider than the artery. So these cranial lobar vessels show us we've got venous distension, which is compatible with this large left atrium here, causing the alveolar infiltrates we see. So signs of acute heart failure, tachypnea and dyspnea are cardinal signs of acute heart failure. Cough can be a sign associated with pulmonary edema, but predominantly coughing in dog is caused by lower airway disease, potentially in combination with left atrial dilation or cardiomegaly, but cough is not caused only by pulmonary edema. That's a very important thing, because if you are seeing a dog that's got a heart murmur and a cough, and you're presuming they're in heart failure, then actually you may well be wrong if their respiratory rate is normal. So remember, look at the respiratory rate first to say if they have signs of pulmonary edema or not, and then if they have a cough, well, fine. Focus on the respiratory rate, don't focus on the cough. Treat with diuretics to control the respiratory rate. Don't try and control the cough with diuretics. That's not going to work, because airway disease only partially responds to the non-diuretic effects of furosemide. So don't forget, in your patient, your old dog with a loud left apical murmur, it's probably got mitral valve disease. That is a population of dogs that also very commonly is affected by chronic bronchitis. So coughing is not a cardinal sign of heart failure in that population. Orthopnea is adopting a posture, often elbows adducted, neck extended, much like this dog in the photograph here. So that this is a posture that's air hungry. It indicates very severe dyspnea, and it's something that is very worrisome when you see dogs doing this. Often because they can't breathe, they've got fluid in their alveoli, they're drowning, they're in distress, so it's understandable to see why they may be very unhappy and may require some sedative to break that anxiety as part of their management. Common diseases causing acute heart failure in dogs. We have the Cavalier on the left here. This is the poster child for degenerative mitral valve disease. We also have the Doberman Pinscher, and the Doberman is the poster child for dilated cardiomyopathy. We do see DCM and mitral valve disease in other breeds of dog. Any small breed dog less than 15 kilos is at greater risk of mitral valve disease than a large breed dog. And large breed dogs and giant breeds are much more likely to suffer from dilated cardiomyopathy than their small breed counterparts. Boxer dogs are a breed that we do see affected by a condition called arrhythmogenic right ventricular cardiomyopathy. That can cause arrhythmias and heart failure signs. It can predominantly affect the right heart, so they may present with right-sided heart failure, but sometimes it looks a lot like DCM. There's a bit of an overlap in that Venn diagram between ARVC and DCM in boxer dogs. Actually, there's a number of those dogs that probably will have ARVC that look like DCM, and people will use the terms almost interchangeably. But we see boxer dogs commonly with right-sided DCM signs, if you like. And that cute fella on the right there is, the puppy, is a dog with a patent duct arteriosus. So I see quite a lot of congenital heart disease. In my population, it's a weird tertiary referral setting. When I was in primary care practice over 6 years working in general practice, seeing a lot of cardiology for a big hospital, I saw a handful of congenital cases, really, maybe 10 to 15, I guess, over that period of time, that had any significance. And I saw 2 dogs with a patent duct arteriosus, which needed occlusion. Without occlusion, the death rate by 1 year old is 50%, and many of them present with signs of pulmonary edema and left-sided heart failure. So why do you get acute pulmonary edema? Because all of these diseases we're talking about are longer-term diseases. They progress over time. So why does one day the dog seem fine and the next day they come in drowning? Well, there's a few things that can happen. We may have a drop in systolic function, which suddenly reduces output. If you suddenly reduce output, you will acutely back up blood behind that left ventricle, which of course is the atrium, the pulmonary vessels, and therefore you can get pulmonary edema. The same thing may happen if you get an obstruction to left ventricular output. You drop left ventricular output, you increase pressures in the heart, and blood backs up behind that obstruction. You may have a sudden worsening of mitral regurgitation, or you may have obstructed pulmonary vein inflow. That's a bit of a weird one. An obstruction to LV output is a little bit of a weird one. Most commonly, we see a drop in function or worsening mitral regurgitation. So you can see how if you drop systolic function or obstruct output, it's functionally the same thing. You have increased pressure in the left ventricle. Worsening mitral regurgitation directly will increase pressure in the left atrium, and increased pressure in the ventricle will feed into that. That will increase left atrial pressure. And that will increase pulmonary venous pressure. Of course, if we obstruct inflow from a pulmonary vein, we do get increased pressure behind that. So think of it like a plumbing system. If you block that flow, pressure will increase behind it, and therefore we can get transudation of fluid into the pulmonary circulation, or pulmonary edema. Sorry, this is animating again. Not quite sure why. My fault. So things that drop function acutely, we might have an arrhythmia. So dogs with dilated cardiomyopathy often get ventricular arrhythmias. ARVC, they get arrhythmias as part of the complex of disease. So that can acutely drop function and therefore increase pressure in the left ventricle. We may have ischemia or infarction. That can happen in cats with HCM. It can happen in humans with coronary artery disease. Why might we obstruct left ventricular output suddenly? Well, we might have a tumour or a thrombus, pretty rare. The biggie that we see worsening mitral regurgitation is rupture of a chordae tendon. So rupture of part of the support apparatus of the mitral valve, causing a big leak in that mitral valve and therefore acutely increasing left atrial pressure. Endocarditis, so an infectious process leading to poor coaptation of the valve leaflets and therefore a leak of blood that can happen fairly rapidly over a day or two, that can cause acute increases in left atrial pressure. Far less common than mitral valve disease causing rupture of the chordae tendons. And finally, we might get a tumour or thrombus obstructing pulmonary vein inflow. It's not common, I've seen it, but it's out there for you to be aware of. So what makes canine heart failure happen? We talked about DCM, we talked about mitral valve disease. We're going to focus on those things because everything else is pretty rare. So we're going to talk about DCM and mitral valve disease. Bear in mind the prevalence of mitral valve disease in general practice in the UK, based on real data out there, is approximately 3.5%. That's across all dogs. So we talked about the smaller dogs being at risk. That's a much higher prevalence of mitral valve disease. Probably 1 in 10 small dogs that walked into your consult room has got mitral valve disease. Not saying they've got heart failure, saying they've got heart disease, which of course eventually can lead to the process of heart failure and fluid accumulation. The prevalence of dilated cardiomyopathy is much, much harder to know. The answer is we don't know what the prevalence of DCM is. We know that dogs who present with heart failure and DCM probably make up 10% of the heart disease that we see in clinical practice. But as for the proportion of dogs out there who are affected by it, we just haven't got a handle, because some of those dogs will drop dead with arrhythmias before they ever develop signs. Many of those dogs don't have a heart murmur. Over 60% of dogs with DCM in a number of studies have got no heart murmur identified. So they're very hard to pick up in the early phases. It's a bit of a silent killer. It's out there. We literally have no idea how common it is. All we can say is particular breeds seem predisposed, and it tends to be large or giant breeds that are predisposed. Family history is quite important. So if the owner had a dog from the same breeding line that was dead at 6 with heart failure, you know what? The next dog they get from that same breeding line probably should be screened around the age of 5 or 6 looking for heart disease. Look at the radiograph here. Quite different to the last one we saw. This dog has got a humongous heart. Look at the size of that cardiac cell. The left atrium, if you follow the caudal border, touches the spine. So this dog has got huge cardiomegaly, but it is not in heart failure. So it's important to remember that disease does not equal heart failure. Let's think first about dealing with DCM. This poor chap here is sitting in front of his own echo, which is a bit sad, isn't it? Because generally it means they've got something bad when we take photographs like that. This is a Labrador Retriever, not very commonly affected by DCM, but when we do see it, it can be quite bad. Typical presentation of a dog with DCM. Larger breed dogs. There's an exception to that. That's Cocker Spaniel. We do see DCM in Cocker Spaniels. Middle-aged to older dogs are typically affected. Although it is genetic, we know that it's got an age-dependent penetrance. So it comes on with age. Like most heart diseases, HCM in cats, mitral valve disease, they're probably genetically coded, but various other genetic and environmental factors trigger that onset in middle to older age. The exception is the Portuguese water dog, who, as I'm sure you'll all remember, has an autosomal recessive form of juvenile DCM. So if you ever see a young Portuguese water dog, they don't walk into the clinic every day, but if you see one that's a young patient who's dyspneic, I don't really care if they have a murmur, you need to rule out cardiomyopathy. They tend to present with left-sided heart failure, so pulmonary edema, and they may present with arrhythmias, atrial fibrillation or ventricular arrhythmias. The classic for atrial fibrillation is the Newfoundland and the Irish Wolfhound. The ventricular arrhythmias tend to be more likely the Great Dane, the Doberman, the Boxer. So there seem to be different breeds affected by different types of arrhythmias. Amongst those breeds with ventricular arrhythmias, sudden cardiac death is reasonably common. So here's an echo. It's a right parasternal long axis view. We see the left atrium here, the left ventricle to one side of that, and the mitral valve in the middle. Okay, the right heart is in the near field. So here we've got left-sided cardiomegaly, very poor systolic function, and also what looks like left atrial dilation, just eyeballing that. This is a classic image of a dog with dilated cardiomyopathy on echo, very rounded looking left ventricle, not just dilated, but hypofunctional and globoid in appearance. They often do have some mitral regurgitation. We can see the little green jet of turbulence here on colour flow Doppler, but that is a secondary feature. It's not like mitral valve disease where that comes first. Mitral regurgitation of DCM only happens when the heart stretches so much the valves fail to meet and close properly. It's not a perfect image. We've got a short axis here at the left ventricle. We can see papillary muscles here. This is what some people call the mushroom view, but actually we can just eyeball that and say that this function is very, very poor indeed. This is an M mode, so we're taking a measurement across that left ventricle along this line of the cursor. So we're looking at the walls moving. We've got the interventricular septum up here. We've got the free wall here, and we can see with the simultaneous ECG, we've got systole, QRS complex, and we've got a contraction after that. Oh, a very good contraction. So actually this is a very poor function indeed. Normally this contraction means that the lumen of the left ventricle here reduces in size by somewhere between 25 and 40%. And here I would say it's at the most 8 to 10%. Here's a view in short axis of the heart at the left base, optimized for the atrium. So we have the aortic valve in the middle, like a Mercedes-Benz sign, 3-leaf clover. And down here we have a large left atrium, an auricle just off to one side. This left atrium should be no more than 1.5 times that aortic diameter. So I reckon the atrium should come to here where the laser pointer is, and in fact it comes right down to here. So this is huge left atrial dilation, which fits with poor function, poor output, and increasing pressure behind the heart. This is a radiograph that should never be taken. This is a dog with very, very severe heart failure signs who presented coughing up pink-tinged fluid, had a quiet heart murmur, was a Doberman. I didn't take the radiograph, but a colleague did overnight one night because they just wanted confirmation it was heart failure. The problem with this is it's quite risky to lie a patient on their side when they're in that state, but they were managed very well. They were given some diuretics, responded beautifully. By the time I saw them, they were fast asleep in the kennel with a normal respiratory rate. But this is such severe heart failure, it merits showing the image. So we can see we've got a very dense alveolar pattern, so dense you can see the bronchial tree sort of in a negative imprint. These are called air bronchograms when you see this. And this is a beautiful example of air bronchograms going cranially and dorsally and caudally behind the heart. To see them like that is really unusual. And the other thing is that it's such a dense alveolar pattern, the soft tissue density in the alveoli actually efface the margins of that caudal vena cava, which should be here. Maybe I can see the ventral border of it, but I can't see the dorsal margin of that caudal cava well, which is telling me this is such a dense alveolar pattern, we're in serious, serious trouble. So how do we assess these patients? Well, observe their respiratory pattern and their respiratory rate. Should be a rapid, shallow pattern, and a fast respiratory rate over 40 breaths a minute is suggestive of pulmonary edema. Of course, you can get the same pattern with respiratory disease, pleural space disease, pyothorax, neoplasia, etc., etc. But in the right signalment with other physical exam findings, this is suggestive of congestive heart failure. Thoracic ultrasound would have been a better way to assess that dog that we just looked at the X-ray image of. So you need to look for B lines. And those are comet tails, so vertical lines that move backwards and forwards across the ultrasound sector as the dog breathes and extend from the pleural margin, which is the near field on the ultrasound, off the bottom of your sector angle. It's very easy to find B lines with a bit of practice. You don't need a particularly good scanner to identify them. If you have greater than 3 B lines, comet tails or lung rockets, some people call them, bilaterally, cranial and caudal, this is likely to represent alveolar edema. It's not a perfect test in dogs, but again, in the right signalment with the right history and other physical exam findings, this would be suggestive. Systolic blood pressure can be useful. Often they're a little hypotensive, by which I mean, 100 millimeters of mercury rather than 120 to 150. It's rare they're hypertensive, although of course that is possible. If you're getting an immeasurably low blood pressure, that's a very useful thing to assess because we need to know if this animal is significantly hypotensive or not. If it is, then we're concerned about renal perfusion. Get an ECG. Make sure that the tachycardia you're observing, probably on physical exam, is actually sinus tachycardia and not ventricular tachycardia or atrial fibrillation. You could think about getting an SpO2 on a peripheral mucous membrane or an ear. That can be helpful, but in my experience, it's poorly tolerated. So, first line treatment. Well, oxygenation. We provide them with oxygen. Flow by prongs. Sometimes we call them prongs of death because often they don't tolerate them when they're feeling good, but they may tolerate them if they're quite dyspneic. Or maybe an oxygen cannula if you haven't got a large patient. I would tend to just, if your heart failure is on your list, I would tend to give furosemide, 2 mg per kg IM. IV is preferable, but you may not have IV access at this point, and you may be worried about stressing the animal too much by putting an IV line in. So maybe the first dose IM is fair. And I tend to sedate them. I tend to use butorphanol, 0.4 mg per kg IV or IM, plus or minus a homeopathic dose of ACP, by which I mean just literally a needleful, really very, very small amount, just so you can see it in the hub. That's enough. Mix that with the butorphanol and use that to provide axiolysis to these patients. If you know this animal has a history of heart disease, or you're pretty convinced it's heart failure, you could give pimobendan, 0.15 mg per kg IV, or you can give an oral dose, which more people have on the shelf in their practice, 0.25 mg per kg per os. The oral dose is pretty rapidly absorbed, but the IV dose, of course, is more rapid, and they don't have to be in a position to tolerate oral medication. Unfortunately, the bottle for the IV dosing doesn't have any preservatives, so it's horribly expensive. If you've got a small dog, you draw it at once, you've got to throw the rest away. You can't use it for the next dose in 12 hours. There are a number of supposed contraindications to using diuretic treatment in patients who present with heart failure. Now, first of all, it's worth saying that actually a fair number of dogs with heart failure will have renal compromise, and that's because of a chronic reduction in cardiac output, which reduces, obviously, blood supply to the kidney, which can cause chronic kidney disease. Now, we may not know about that because the dog may not have clinical signs or even biochem changes until we've already lost 75 or 80% of nephron function. So if we've got a dog in heart failure, they've got low cardiac output, we're giving diuretics, we reduce circulating volume further, that could reduce renal perfusion and therefore worsen the situation of hypotension-induced kidney injury. So we may exacerbate this thing that is already a risk in these dogs. The other thing is that furosemide has to be filtered into the tubule to actually work on the receptors that it works on the loop of Henle, because it works on the tubular side of the sodium-potassium chloride cotransporter. So if it's not filtering because of reduced GFR, then it won't work as well as it should. And that is true. However, I have a bit of an issue with these things. If this puts us off giving treatment that stops the dog from suffering, that's not okay to me. I think we need to look at it in a different way. Now, we all know from perhaps being taught biology at age 15, 16, 18, that cardiac output is related to preload. This is the Frank-Starling law of the heart. So as we increase preload, if we look at this graph on the x-axis, the increase in preload will increase cardiac output. And that increases in a fairly linear fashion in the physiologic range, but it will plateau out. So it gets to a point where increasing preload does not increase cardiac output because the sarcomeres within the cell are already stretched to their optimal levels. What if we stretch them more? If we stretch those sarcomeres, those overlapping A bands and Z bands, if you remember, that they'll overlap, and if we optimize the stretch, we get a good, strong contraction, which is what's happening in that physiologic range. But actually, if we go beyond that, we stretch them further, we reduce the amount they overlap, we take them further away from the optimal level, and therefore we can reduce cardiac output by overstretching the heart. This also will increase myocardial oxygen demand and damage the heart in other ways by promoting ischemia. So acute heart failure tends to happen on the descending limb of the Starling curve. We're never taught that, we never think about that, because we're taught and we think about the physiology, but this is pathophysiology. So here we've gone beyond that physiologic range. So what if we give diuretics? Diuretics reduce preload. Intravenous furosemide has two great actions. One is its diuretic action, which starts to work very well at about an hour after you give a dose. The effect that intravenous furosemide has in addition to that does not happen with intramuscular oral dosing is venodilation. Now, venodilation is dilation of the capacitance veins, the splanchnic vessels, the great veins in the thorax, which stops blood coming back to the heart. Now, any blood that comes back to the heart ends up in the left atrium, and that's where we've got the problem. So if we stop blood coming back to the heart in this particular situation, in the situation of heart failure, that will reduce preload and therefore will actually consequently increase cardiac output. It's a bit strange sounding, but that venodilatory effect of IV furosemide is very, very useful. That occurs about 20 minutes after an IV dose. So if you're looking at a dog after 45 minutes and saying, oh, the furosemide hasn't worked, well, you know what, the venodilation hasn't been enough, but it's not really you're not really allowing it time to have the diuretic effect. So you really want to try and wait a couple of hours after an IV dose of furosemide before you say it's not working, if you can. You may need to top them up sooner than that to see if you can get a dose-dependent effect. So if we give diuretic, we reduce preload. We take them back on the Starling curve, and therefore we increase cardiac output. And that seems like a difficult pill to swallow if you think about circulating volume, but I'm thinking about cardiac pathophysiology. So if we give diuretics, we reduce preload, we increase output because we take them back towards the physiologic range of the Starling curve. So therefore, furosemide will increase renal perfusion, and therefore the diuretic effect will work better by the time it has got to work. So how do we monitor these patients? We give them IV furosemide, I said pimobendan, and we monitor respiratory rate and effort. We would expect their respiratory rate and effort to reduce as the severity of their pulmonary edema reduces. Now that may be because of the venous dilation induced by furosemide, it may be because of diuretic effect, it may be because of pimobendan reducing left atrial pressure. We know it does that. It may be because of sedative effects of butorphanol, homeopathic ACP, which is helping to reduce catecholamines and therefore reduce the adverse effects of catecholamines on the heart and systemic vasculature. So we've got a number of different things we've already done which should be helping to reduce that respiratory rate and effort. Blood pressure, keep an eye on that. We would hope it will increase as cardiac output increases. ECG, look for ventricular arrhythmias. If you don't have an ECG monitor, they're not that expensive. It's worth getting one for the clinic, and it's worth at least keeping an eye on heart rate if you only have a paper trace, because we don't want to keep the paper running and waste rainforests. Keep an eye on the heart rate, keep an eye on the heart rhythm, and run a paper ECG if you're not sure they're in sinus rhythm, because ventricular arrhythmias may occur, or atrial fibrillation may occur during treatment, owing to the stress that the patient is under and the increased cardiac work that the heart is having to deal with. You can monitor SpO2. I'm not a massive fan because it's not massively well tolerated. I question its accuracy in a number of cases. However, it can be useful. And you can monitor that thoracic ultrasound, those B lines, because if we can identify that the B lines are becoming less numerous and less dense, we know that the density of B lines correlates quite well with severity of edema. So if we monitor thoracic ultrasound over time, we will see those B lines reducing in density, reducing in number, and therefore that will suggest that the pulmonary edema is resolving. That may occur in tandem with respiratory rate, but sometimes you have a patient who's quite hard to assess. Maybe they're really brachycephalic, maybe they are very stressed, maybe it's hot, it may be hard to identify their respirate, and therefore the thoracic ultrasound can give you an additional parameter through which to use monitoring of edema without taking repeat radiographs in lateral recumbency, which may pose a risk. So what are we aiming for when we treat heart failure? Well, we're aiming to see a reduction in respiratory rate over 2 to 4 hours. We don't need it to be normal, we just want it to improve. If there's no reduction in the first 1 to 1.5 hours at all, repeat the furosemide, because you may get a dose-dependent effect on venous dilation, you may get an additive diuretic effect with time. Aim to maintain systolic blood pressure over 100 or round about 100. And aim to have respiratory rate less than 40 within 12 to 18 hours of admission. It's not going to happen after one dose of furosemide. It's not going to happen, immediately, unless you have that one exceptional dog who responds incredibly well. So they don't have to be normal. Normal to me is less than 30, but in hospital I allow up to 40, and certainly if they've come in with a respiratory rate of 50, 60, 80, well, 38 is great. When would I begin to worry? So if we don't have a reduction in respiratory rate after 6 to 8 mg per kg furosemide over 2 to 4 hours, I'm worried about that. That's bad news to me. Or if they're deteriorating in the first couple of hours despite furosemide treatment. I know furosemide takes an hour or more to have a good diuretic effect. However, if they're getting worse, maybe we don't have time to wait. How can we deal with these dogs? We need to improve cardiac output. The aim of that is to increase tissue perfusion, but also as we get more forward flow, more blood leaving the heart, then we will reduce the left atrial pressure because there'll be less blood sitting behind the heart if the pump is working better to get blood forwards. We can try and aim for an improved diuretic response, so we can then try and give them more oomph to that furosemide dose to deal with the pulmonary edema that's induced by their DCM. How can we do it? Well, the first step to consider is dobutamine. So dobutamine is a racemic mixture of isomers. It's fairly irrelevant, other than to say one isomer does one thing, one does another thing, and they sort of balance out so that they cause largely a selective beta 1 effect. Now, beta 1 adrenal receptors are primarily located on the heart. So dobutamine is pretty cardio-selective. It's not perfectly specific because it does have a weak beta 2 agonist effect. So the beta 2 agonist effect will cause a mild vasodilation. The beta 1 agonist effect will cause a strong, selective, positive inotropy and chronotropy. So it increases heart rate and it increases stroke volume by improving contractility. It also improves cardiac filling and some other things too, conduction velocity and other stuff. Now, it's really important to remember heart rate and stroke volume multiplied together increase cardiac output. So we're increasing heart rate, increasing stroke volume, and that will improve cardiac output. This is life-saving for dogs with dilated cardiomyopathy. It can absolutely help them turn a corner. The dose to start at is 5 micrograms per kilo per minute, and normally I just draw up some dobutamine as a neat infusion. Now, negative effects of dobutamine, we are asking a failing heart to work harder. This heart is already starved of oxygen. It's already working on inefficient metabolic pathways that have been switched from the normal high efficiency pathways over the last few months or years as DCM has developed. So we're increasing oxygen demand, we're promoting ischemia, and also by increasing heart rate and changing the calcium cycling within the cell by affecting these beta 1 adrenal receptors, we're loading the intracellular organelles with calcium. That can cause calcium sparks, calcium eruptions. That can be pro-arrhythmic. So loading with calcium, promoting ischemia, has a net pro-arrhythmic effect. So we must monitor these dogs for ventricular arrhythmias. This is where if you don't have an ECG monitor, you're going to want to get one if you're seeing these patients. So how do we monitor? Well, we have to have a continuous ECG. You know, if you don't have a continuous ECG, there's a possibility you're going to miss bad arrhythmias and therefore make the patient worse by giving this drug. It's a bit of a fine line. You know, can you just monitor heart rate? Well, yes. And then ECG, you know, with paper ECG, intermittently, or one of those iPhone ECGs, the AliveCore app. But actually, it's fairly cheap to get an ECG monitor, a basic ECG monitor now, and I think most practices should have one if they don't, you know, petition them to get one, because I think it's, you know, $300-500 could well spent. Monitor blood pressure 5 to 10 minutes after starting them on dobutamine, and if it's not improving, increase the dose. And monitor again 5 to 10 minutes after the change in dose. So if there's no increase in heart rate after an hour, you can up that dose by 50%. So you can go to 10 mics per kilo per minute. So you can go from 5 to 7 to 9 to 10 or something. I don't tend to go beyond 10 because beyond that often you do see a pro-arrhythmic effect. If you do get a pro-arrhythmic effect, ventricular arrhythmias predominantly, drop to the previous dose where it wasn't an issue. The problem with dobutamine is you're stimulating sympathetic nervous system, and actually the body is quite good at adapting to that increase in sympathetic drive. So what happens is the myocardium becomes tolerant after about 2 days. So therefore, you know, the first 24 hours is your window in which you can help. After 24 hours, generally what happens is the effect drops away. So if you're not seeing a significant improvement after 24 hours, it's probably pointless to continue. And that would be a fair endpoint to say to an owner, we're going to start an intravenous drug now, which will help to improve function, help to improve output, and hopefully help your dog. However, we're going to give it a day. And if by 2 p.m. tomorrow, whatever, he's not looking significantly better, then actually we're in trouble. And probably that is time to consider euthanasia. Now, furosemide can be given as a continuous rate infusion, and that may be beneficial because it reduces the peaks and troughs we see in giving furosemide as boluses. So on the left here you can see boluses will bring the drug into the therapeutic range and then down again. If we give a continuous rate infusion, we do give an initial bolus to get it in to the dog, but then we start the CRI and we can up titrate that and work on it with time. You'll get well into the therapeutic range and stay in the therapeutic range. This peaks and trough effect in humans is associated with an increased risk of renal injury. So actually, by putting them on a CRI, we may be able to help them that way. There's a couple of studies done in dogs comparing the two regimes. And actually, the CRI doesn't seem to have a better diuretic effect, but there's this theoretical benefit to renal function. The other benefit that I observe is that if I've got a busy ICU and I'm leaving for the night and saying to the junior vets or to the nurses, hey, look, there's this dog here, you've got to assess it, you've got to give it furosemide, 1 to 2 mg per kg every couple of hours, and they're really busy. That's quite a lot to deal with. Now, we're lucky we have a nice full-time team and they're very experienced, but sometimes they're just stretched thin. So in those scenarios, what I tend to do is put them on a CRI, because actually, put the patient on CRI, you're asking them to do fewer things. What you do, assess them, is the rest rate increasing? Yeah, you know what, just jack up the CRI just a little bit, and then reassess them in a couple of hours. And actually then it's something whereby the level of thought for the staff is minimal, and the level of stuff they have to do is minimal. It's more efficient. It's a bit of a faster setup, but it's more efficient overnight. And that may be useful, I think, in primary care practice if you maybe just have one nurse on overnight or a night vet who's also busy and you don't want to ask too much of them. It really helps their efficiency overnight to use a CRI. So I like to give a CRI as a hypertonic solution. Kind of a weird concept, because hypertonic saline is normally used for volume expansion, isn't it? If you've used it in GDVs or something like that, or talked about it in GDVs, then you know this will cause volume expansion pretty rapidly. Actually, hypertonic solutions will help to suck fluid out of the lungs back into the blood vessels using that osmotic effect. That's exciting, but if we wait too long with a hypertonic solution like hypertonic saline, then that will cause a big increase in circulating volume and will massively increase the heart's workload. However, we're giving furosemide with it. We're piggybacking them together. So what happens is you get a big hypertonic effect to suck that fluid out of the lungs, and the diuretic effect simultaneously to make them pee the fluid out. So hopefully that fluid doesn't really increase left atrial pressure. And we know that doing this is safe in dogs, and the outcomes are as good as boluses. We also know from one very nice study that this activates the renin-angiotensin-aldosterone system, which is already out of control, less than just giving furosemide in an isotonic solution. So hypertonic solutions benefit the patient, at least biochemically. So I like to use a slightly complicated cocktail of hypertonic furosemide as a CRI in these bad patients that don't respond to a couple of furosemide boluses. Here is a genuine calculation I did just to prove that I am a clinician. I don't sit, in my office at home and pre-record webinars all the time. I see patients, and this is a patient who was in heart failure with actually mitral valve disease in this case, and we put him on a CRI of furosemide. And we use this calculation to help us work out what the recipe for the hypertonic furosemide is, and also what the rate of infusion should be. So what we tend to do is we will dilute 15 mils of hypertonic saline with 30 mils of 5% glucose saline. So that's D5W, dextrose 5% in water. It's the American term. The criticalists like it. It's easy to write, so I use it. So 30 mils of D5W. We don't buy bags of that. We just make it up using saline and glucose. So we use the D5W 30 mils, 50 mils of hypertonic saline, and then into that put 100 milligrams of furosemide, which Dimazon, which is the licensed prep in the UK, we'd use 2 mils of Dimazon because that's 50 mg per mil. So 2 mils of Dimazon plus the rest makes 47 mils, which fits very nicely in one of those big BD Plastipack 50 ml syringes. So we can use that in a syringe driver. And that makes a solution that is 2.2 milligrams of furosemide per mil. So if we infuse that to achieve an initial dose of 0.66 milligrams per kilogram per hour, then we can use that concentration and that dose rate to work out how much the patient needs. So this was a 7.6 kilo dog, and for a 7.6 kilo dog, it worked out at 5 mg per hour, which at this concentration was 2.3 mils per hour of the CRI. So the continuous rate infusion wasn't giving the dog lots of IV fluids, not even maintenance fluids, nowhere near. We're just trickling that in using the syringe driver. And we can assess the response to this and we can up-titrate that as required. Be a little bit careful about going very high on the doses, because don't forget, if we go to a mg per kg per hour, which would be, increasing this not even 100% from where we're at, then overnight you're going to have given 12 mg per kg, which is quite a hefty dose of furosemide. It can lead to hypokalemia and dehydration. So don't get carried away, but you can increase it higher than that short term and then back off it as the dog improves. So try and titrate to effect and assess the dog every couple of hours if they're on CRI. Bit of a faff to set up, but it might be less work overnight. So your colleagues may thank you, and your patients may thank you as well for helping get a better response. So what are our endpoints for severe DCM? Well, positive endpoints. We have a controlled respiratory rate on dobutamine and furosemide, and we've weaned the dobutamine out after 24 hours because it doesn't work forever, and the respiratory rate stays normal. Fantastic. They have to be tolerating oral medication before I'll send them home. I don't really like owners injecting meds, even in a patient who's stressed. So I think tolerating oral meds is important. Eating, and hopefully their potassium is within the reference. If not, we need to supplement or start spironolactone, which will help to conserve potassium. We do see hypokalemia as a result of intensive furosemide therapy fairly commonly. Negative endpoints: a lack of response to dobutamine at 10 mics per kilo per minute, or ventricular tachycardia in the face of dobutamine that is helping them, or we can't wean the dobutamine CRI without seeing their respirate increasing again. We've got to think about euthanasia for those patients. So what's the point given a 24-hour infusion of dobutamine or furosemide CRI when we've got a chronic degenerative myocardial disease? Won't they just get worse again when we wean the infusions? I can hear the questions in your minds now watching the webinar. Well, dogs can massively increase their pulmonary lymphatic uptake by 20-fold. That's a huge amount. Some people say up to 50. So that's a massive, massive capability to deal with increased pulmonary fluid. The other thing is that as the left atrium stretches over time, if we have an acute increase in pressure puts them into heart failure, the left atrium will stretch over time. And that will help to reduce the pressure in the atrium because it will accommodate that pressure. And that will also then help to reduce the pressure in the pulmonary veins, pulmonary capillaries, and therefore reduce the amount of driving force behind that pulmonary edema. So here we can reduce the drive for pulmonary edema, and we can increase the lymphatic uptake of that residual fluid that isn't dealt with by the hydrostatic oncotic pressure balance. So therefore, if we can buy them the time to compensate for whatever has caused them to have an increase in pulmonary edema, then we can save their life. So this is a bridge to them coping better or to them responding to oral medication that we start. Let's think about mitral valve disease now. Fairly different presentation to DCM. So it's almost exclusively small breed dogs, less than 15 kilos in body weight. Exceptions, border collie, they can be smaller than 15, but often are larger. Labradors, we see mitral valve disease in Labradors. We also sometimes see it in Great Danes or German Shepherds. They're often middle-aged to older dogs. We can diagnose it in youth. They don't tend to be in heart failure at age 2 or 3, but sometimes we can see them with mitral valve disease at that age. They often present with pulmonary edema, just like DCM. They can get arrhythmias, but it's far less common than in DCM, and it's almost exclusively atrial fibrillation when you have a very large atrial dilation. This is an echo of a dog with mitral valve disease. You can see left atrium here, left ventricle, the right heart in the near field. Look at the mitral valve, quite different to those previous echo images we saw of DCM. Here we've got a thickened, distorted mitral valve that bends backwards when it closes towards the roof of the left atrium. That's called mitral valve prolapse, and this is characteristic for degenerative mitral valve disease. We can also see a little pericardial fluid here. Now, that suggests this dog is in very acute heart failure. Both sides of the heart are failing simultaneously in this patient. Here's a close-up on that valve, slightly slower for you to see that prolapse. That really is pathognomonic for degenerative mitral valve disease. The walls are moving very well, almost too well actually, but it doesn't look like DCM at all. You see how the function is very different to DCM. And here we have that left atrium aortic root ratio. That's the aorta in the middle, three-leaf clover, Mercedes-Benz. That's the left atrium and the auricle. Look at that. The atrium should come to about there, I think. Probably a left atrium to aortic ratio of 3. And the reference is less than 1.5. And here's the M mode, just showing you wall motion. It looks much better than DCM. Very, very different beast in terms of function or wall movement. Here's a radiograph of a dog with heart failure. Not as obvious as some of the ones that I've shown you before, but we can see we've got a little grey alveolar infiltrate here. Got a big atrium. If you draw an imaginary line between the top of the caudal cava, where it intersects the cardiac silhouette, and the carina, so the bifurcation of the trachea, which is here, an imaginary line there, you should not have any of the cardiac silhouette above it. If you do, that's a big atrium. Okay, so that's the big atrium there. We've got venous distension. The veins here are wider than the artery just here. Okay, so we've got that holy trinity of big left atrium, big veins, and alveolar infiltrates. That holy trinity suggesting we've got the murmur we're hearing is associated with congestive heart failure, or the dyspnea we're seeing is caused by congestive heart failure. So we talked about treating heart failure sort of initially, furosemide, sedation, oxygen therapy, pimobendan. Those are all indicated in patients with DCM and mitral valve disease. We talked about how to monitor that initial response. How then do we deal with poor responders in mitral valve disease? Well, we want to reduce the severity of mitral regurgitation. That will help to reduce the pressure in the left atrium and thereby the pulmonary venous pressure. And we also want to improve forward flow, so increase cardiac output. That will reduce left atrial pressure too. And we want to improve diuretic response. Furosemide CRI, I hear you shout. Well, that's absolutely correct. We can reach for furosemide CRI just in the same way as we did in the dog with DCM. Reducing mitral valve severity is a little different. Now, sorry, not mitral valve severity, mitral regurgitation severity. Now, how do we do that? Why do we do that? Well, if we can improve forward flow, we reduce left atrial pressure. How do we improve forward flow? Let's think about pressures. The pressure within the normal left ventricle is somewhere between 100 and 130 millimeters of mercury in systole. The pressure in the normal aorta in systole, 100, 120, 130 millimeters of mercury. Okay, so it's similar to the ventricle, same as the ventricle. The left atrium, the pressure is much lower, even in heart failure. In heart failure, we may have a pressure of 25, 30, 40 millimeters of mercury. Normal here would be 5. So when we have a pressure this time, we're promoting pulmonary edema. But it's very low compared to the ventricle. So in systole, when the ventricle contracts, blood's going to follow the path of least resistance. Now, if the dog has come into you alive, upright, breathing, it suggests blood is going forward. But there's going to be a lot of blood going backwards through that mitral valve orifice. And actually, over half of stroke volume can go backwards in patients with bad mitral regurgitation. And in acute heart failure, it might be 60, 70, 80% of stroke volume is actually going backwards and is useless to forward flow oxygenation perfusion. Now, because this depends upon the balance between systemic pressures and atrial pressures, we can theoretically reduce systemic pressure to improve forward flow. So if we give an arteriodilator, which then drops aortic pressure, because we cause vasodilation, it improves flow forward through the aorta, we'll drop aortic systolic pressure, and therefore we'll increase the amount of blood going forwards. Well, the mitral regurgitation severity will reduce just by a simple balance, simple fluid dynamics. So actually, by reducing vascular resistance, we drop afterload, and therefore increase forward flow, which reduces left atrial pressure. So we might go from a mitral regurgitation volume that is maybe 60, 70% of stroke volume, might drop it to 30 or 40%. And therefore we reduce the left atrial pressure. So in this particular example, we've gone from 60% of stroke volume going backwards to 40%, and we've dropped the atrial pressure from 25 to 15. These are arbitrary numbers that I've picked, but they illustrate the point that if we actually vasodilate, if we drop blood pressure in the arteries, that's not bad for dogs with mitral regurgitation. It's good. It improves forward flow. We don't want to make them hypotensive, so we drop renal perfusion even more, but we want to make them a little less normotensive, if you like, to improve cardiac output. Sodium nitroprusside is our treatment of choice, okay, SNP. This is a drug which is a very rapid vasodilator, very rapid arteriodilator, and therefore you can give it and titrate it very rapidly to effect as a continuous rate infusion. So this increases nitric oxide production, and nitric oxide is produced by the capillary and the arteriolar endothelium, and it's direct arteriodilator and venodilator. So venodilation reduces blood coming back to the heart, therefore reduces blood coming back into that high pressure atrium. So therefore that will help with reducing left atrial pressure. Arteriodilation will drop systemic vascular resistance, improve forward flow, reduce mitral regurgitation severity. So it's like a two-pronged attack on that left atrial pressure. So we're dropping preload and we're dropping afterload. This is fast acting and very potent. Okay, so you've got to monitor blood pressure when you're giving it. You can just use a Doppler blood pressure, that you don't have to have an invasive line or anything. There are some practicalities to consider of SNP. First of all, check your baseline blood pressure. If it's already less than 80, I probably don't want to drop that further, okay, because you're going to compromise the kidneys. So therefore, check your baseline blood pressure. It's got to be 100 or more to really maximize the benefit. Take your nitroprusside, it often comes as a powder, and dilute it in the diluent with the bottle, but then also dilute it more in dextrose saline, so 5% glucose saline, D5W. You've got to protect it from light. You see the bottle is brown, and you see if we need to wrap in tinfoil or vet wrap or something, the bag, the syringe lines and the syringe driver potentially. So you can start at 1 microgram per kilo per minute. I tend to start at 5 and just assess the response. And after 5 minutes, check systolic blood pressure. If blood pressure has not reduced, increase the dose from 5 to 6, 7, 8, 9 mics per kilo per minute. Push it up, and therefore in 15-20 minutes, you can be at a good operating dose of this drug. Target systolic blood pressure of 80 to 90 millimeters of mercury. Dose to effect. Okay, so go higher if you need to go higher. You don't want to go below about 80. Okay. I know that sounds like I'm making this drug hypotensive, but your mean arterial pressure will still be fine at 80, and therefore you're still going to get decent renal perfusion. Just to show you, I'm not always the neatest in working stuff out. I've got scrap paper on the left where I've calculated everything, and then I'm transcribing the stuff I need to tell people what I'm doing to the page on the right, so then they can make up the infusions later if we run out. Don't do that to your colleagues. Make up enough to go overnight. This is the bit on sodium nitroprusside. Okay. So we've got 50 milligrams of sodium nitroprusside in 100 mils. Okay, so that's not plus 100 mils, that's in 100 mils of D5W. That's 0.5 mics per mil. Important distinction. So if we start at 1 mic per kilo per minute, that's 1 mil per hour in this particular dog. Okay, if we wanted to start at higher dose, like 5 mics per kilo per minute, then obviously we're going to be giving 5 mils per hour. This was a 7 kilo dog. So even with this and the furosemide CRI, which was starting about 1 mil per kilo per hour, we're not even reaching maintenance fluid level. And don't forget, we're giving quite a lot of diuretics. So we're still at a very safe level of intravenous fluids, where we're not risking making heart failure worse from the volume of the carrier that we're giving the drugs to the dog in. Something to consider when you get to higher doses. So this recipe should work fine. Here's the practicalities. On the left here, our 2 syringes. We've got a hypertonic solution of furosemide. And on the right, protected from light, we've got sodium nitroprusside. Got a couple of IV lines in this dog. Sorry, a couple of bandages in this dog. One is an IV line going into the right fore. We did put an ART cath in the back leg because the dog was pretty stressed and didn't like us measuring Doppler blood pressures, but normally I use Dopplers. You can see here in the ART cath, the dog was starting off at 122 millimeters mercury systolic, so we've got loads of room there for manoeuvre. And this is our syringe driver with our sodium nitroprusside going into the patient. And we're monitoring there, we're at 2 mils per hour now, so we doubled the dose from when my calculation started, and we can increase that to effect. When do we stop with sodium nitroprusside? Well, it's pretty toxic after time. After about 36 hours, you start maximising all the metabolic pathways through which it's metabolised and excreted, and the side effect of that is cyanide toxicity. That's a bit naughty, and we don't want to do that. So after 36 hours, we definitely are stopping. I would say 24 hours if things aren't, well, even if things are better, you want to get that out of the system, okay? So 24 hours or sooner, if they're doing better sooner, is when I would begin to wean this drug. Reduce the dose initially by a third, and then reassess, and then reduce again, okay? Aim to discontinue that sodium nitroprusside over 4 to 6 hours. So if you stop at the latest at if you begin discontinuing at 24 hours, then even with 6 hours or 8 hours discontinuing, you're not going to get cyanide toxicity. So it's very safe. I don't tend to worry owners by telling them up front about cyanide toxicity, because hopefully I'm, going to be on the board enough not to drive off the edge of that cliff, because I'm in control of my medicine car. So I don't warn them about that up front. But I do explain sometimes, if it's a hard stop, we can't carry this drug on beyond 24 hours because it's a hard stop, they'll get toxic. Some owners will say, just give them a bit longer, give them a bit longer. You have to be very, very strict. Now, if you don't have sodium nitroprusside, we get it on import license. The other thing you can do is get it from the local hospital pharmacy. They keep a good stock often, and you can just buy it from them. If you give them a purchase order number, they'll invoice you for the drug. That's how we work with our local NHS anyway. But you may not have it on the shelf, and you may not be able to get some out of hours. You could consider reducing arteriolar pressure by using amlodipine. It's licensed for control of blood pressure, but sodium nitroprusside is not. However, SNP is much better because of the CRI capabilities and the capability to titrate to effect. So on Cascade, we can use sodium nitroprusside, although amlodipine is a reasonable thing to give if you don't have access to that. It's oral, it's cheap, easy to use. We've all used it for cats, for dogs, for hypertension. The disadvantage is you can't titrate it to effect. You give it, you have to monitor what happens over the next 12 hours, 24 hours. And if you give it and you make them hypotensive, you can't take it out again. That's obviously not true with a CRI. Alternatives to amlodipine, hydralazine. Most people don't have that on their shelves. It's a very potent arteriodilator. Don't use it alongside other things, especially not ACE inhibitors, because you can get marked hypotension with that. Prazosin, you may have that on the shelf for use in blocked cats for the muscle relaxant effect. It is a useful thing, but I find that amlodipine is a bit more predictable. If you're struggling, you could consider adding it to amlodipine, but you may be risking hypotension, again, in those patients. So what are our endpoints for acute heart failure caused by mitral valve disease? Fairly similar to DCM. So we have to have a controlled respiratory rate after weaning the sodium nitroprusside and furosemide CRI. Got to be tolerating oral medication, eating with a normal potassium. Negative endpoints, well, lack of response to sodium nitroprusside, or they're responding but we can't get them off it. Okay, we can't continue that drug. That's a hard and fast stop. So if we discontinue it for the risk of toxicity and they end up drowning in pulmonary edema again, you're stuck between a rock and a hard place. And again, these are endpoints where you must consider euthanasia as a viable option. So what are our expectations from these heart failure cases in dogs? What prognosis can we expect? Well, the average survival time for mitral valve disease and heart failure is 12 to 18 months. Now that's true even after an acute event. They can do very well. And some dogs do so well after the acute event, they can almost come off diuretics for a while. That's a bold move to do that, but it is possible. Once they develop signs of diuretic resistance, ascites, complicating factors like bad arrhythmias, pulmonary hypertension, we're often talking 6 months or there or thereabouts. These figures are generalizations. They're not true for every dog, and dogs will surprise us in both directions. With DCM, the survival time is slightly shorter, often is 9 to 12 months with dilated cardiomyopathy. Because of the frequency of arrhythmias, sudden cardiac death is much more common in these dogs, particularly in Dobermans, Boxers, Great Danes. If you've got diuretic resistance, atrial fibrillation, pulmonary hypertension, really complex issues in these dogs, then the survival is often pretty poor, 3 months or less. So DCM is definitely a worse disease to have. However, they do surprise us in both directions, again, just like mitral valve disease. So to summarise the acute management of heart failure, acute DCM, you can use dobutamine to bridge that first 24 hours. Acute mitral valve disease, you can use nitroprusside to bridge that first 24 hours. And with both, you can use a furosemide CRI. Now, although most dogs, in my experience, do well with these protocols, some do not respond. and it's very important up front to define clear endpoints with owners. This is how long we'll try for. If he's no better, we're going to have to think about other options, including, sadly, calling it a day. So thank you very much for everyone who's tuned in and chosen to watch, listen. Obviously, normally I would take questions. The way that I'm happy to take some questions actually is through my Instagram account. I'm at vet_cardio_. So please feel free to follow or not. It's up to you. But you can message me and ask me questions about the presentation there. And that even goes, after the initial viewing of this student focus in January. That goes as long as it's online for. So if anyone wants to get in touch, feel free. Happy to chat about cardiology in general. And on that profile, I do post some other cardio stuff. I don't make any money out of it, so there's no conflict of interest here. Thank you very much for tuning in, as I say, and I hope you've learned something useful. That photograph there just shows the Clifton Suspension Bridge in Bristol in the Avon Gorge, which is one of the most wonderful places and the best things about where I live.